Hello and welcome to this presentation on the management of hemoglobinopathies in Denmark. My name is Andreas Glenthøj. I'm a medical doctor and I head the Danish Center for Hemoglobinopathies here in Copenhagen. And first of all, my apologies for not being physically in Stockholm, but thank you very much for the opportunity to talk about the Danish screening program and treatment of patients with hemoglobinopathies. I would like to talk a bit about the Danish healthcare system, a bit about the organization of the hemoglobinopathy treatment, about our Center for Hemoglobinopathies, about the screening program, and last but not least, how we clinically manage the patients here in Denmark. So first of all, the Danish healthcare system is quite similar to the other Nordic countries. It's a publicly funded healthcare system, so it's free for the patients. We have some decentralization with 5 different regions in the country, and we have a few private hospitals, but none of them take part in the treatment of patients with hemoglobinopathies. So the Danish health authorities, they have planning of rare diseases. So in this case, in sickle cell disease and in thalassaemia, they have centralized it to very few hospitals. And most of the patients are followed at my institution at Rigshospitalet in Copenhagen, but Aarhus also treats adult patients with hemoglobinopathies, and Odense treats patients as well, but under my supervision. In pediatrics, there are also Aalborg who treats some patients, and Odense is allowed to treat patients independently. But all in all, we are a small country and we collaborate quite a lot. So even though the health authorities have decided how things should be, we very much try to help each other. And given the rarity of the diseases in Denmark, we try at our center to help patients all around the country with specialized treatment, new protocol options, and writing guidelines for clinical management. And usually when there's a complicated case, for instance, a patient with sickle cell disease in another part of the country that has severe complications, very often they contact our center to talk about what might be beneficial in this regard. And also I'm very humble in having very few patients, so I often consult international colleagues as well when I have doubts, which is not that rare. So my center, the Danish Center for Hemoglobinopathies, we are 2 physicians, me and Nina Toft, who treat the patients. We have a diagnostic laboratory, but really I shouldn't take too much credit because all the work was done 30 years ago when my mentor, Professor Henrik Behrens, he founded the facility, did the diagnostics, and saw the first patients that came to Denmark. So most of the honors should be his. Recently we became members of EuroBloodNet, and I think that's been very good because it allows us to collaborate on clinical protocols and diagnostics, epidemiology, registries with international colleagues in the European Union. To compensate for the rarity of the diseases in Denmark, we have very much centralized the care. So most of the patients are followed in Copenhagen. And even though our name is the Danish Center for Hemoglobinopathies, we also treat other hereditary anemias, membranopathies, and last but not least, enzymopathies. And in particular, my main interest outside hemoglobinopathies is pyruvate kinase deficiency. So we really try to manage all types of these hereditary anemias. Our laboratory does a lot of tests, more than 5,000 every year, and over the years we've tested many different individuals, both from Denmark, mostly from Denmark, but also a lot from Sweden and some from Norway. And we try to help with the advanced diagnostics that we try to build in ion channel measurements, exocytometry, other diagnostic options that are not widely available in the Nordic countries. So just to stress that point, we see ourselves as a center of hereditary anemias, but in volume the hemoglobinopathies are of course the most important ones. In research, we try to, and we think it's our obligation to do research both in clinical protocols and in basic research and diagnostic improvements in the spectrum of hereditary anemias. In sickle cell disease, we've had a PhD student who traveled to London and is planning to travel to Africa to study sickle cell anemia. In pyruvate kinase deficiency, we've had several protocols with target treatment with mitapivat. In thalassaemia, we have had a phase 2 study recently that has closed now, and we have 2 phase 3 studies that are about to start with mitapivat, targeted treatment there, that should be available to all patients from the Nordic countries. We've translated the patient information to Norwegian and to Swedish. We have membranopathies, we have gene therapy where we are approved to give gene therapy with Zynteglo, but as you probably know, this has not been approved in Denmark or any other Nordic country. So we're not able to give it, allowed to give it, although we are technically able to do so. And we also do a lot of epidemiological research to highlight the burden of disease of these hereditary anemias, really to highlight how important they are, both economically but also socially for the patients. So it's no secret that we get more and more tests, more and more patients for every year that goes by. These numbers are a bit old. Now we do more than 5,000 hemoglobinopathy tests every year. So it is a rapidly increasing number, both because we do more diagnostics, we're better at locating patients that should be screened for hemoglobinopathies, but also we get more patients who are at risk of having a hemoglobinopathy. It pretty much reflects how things are in the world, and it's no secret that there has been many wars around the world, and we see patients from Syria as we used to see many patients from Iraq back when there was an active war there. So really, as you know, it's not a rare disease, and I think in the Nordic countries it's not anymore. It's not a common disease, but it is becoming increasingly relevant. So I think having a meeting like this, highlighting that we should screen and treat patients properly, I think that's very, very important. So we know that we have around 67 patients with beta thalassemia intermedia and major in Denmark. Approximately half of them are adults, half of them are children, and most of them have been diagnosed at my laboratory, so we know the exact genotype of all the patients, more or less all the patients. With sickle cell disease, we have 107 patients approximately. Most of them are SS, and again, most of them are followed at my institution, so we know all of them, and all of them have direct access to our clinical department. But really, to highlight that these diseases are important, we do have a screening program, and that has been going on since 1995. And it is being built on all the time and it being improved. But I think it's been very successful overall in providing a reproductive choice for the parents who are at risk of getting children with a severe hemoglobinopathy. It's no secret in this audience that there have been screening programs since the 1970s around the world. And as I just mentioned, we built one in Denmark. But contrary to how things are in Cyprus, there is no great need to screen the entire population. We just need to screen the at-risk patients. So how do you do that? Well, we built in Denmark a system adapted for a low prevalence country with an at-risk population. And our focus in the screening program is to locate pregnant women who are at risk of having a hemoglobinopathy, most of them without actually knowing that they are at risk. So ideally, as you can see on the flow chart here on the right, at the first visit with the GP after you get pregnant, you should be asked whether you have roots outside Northern Europe. And if you have that, you should be tested for hemoglobinopathy. And if you are carrying hemoglobin S or thalassaemia, your partner should be screened as well. And if both parties carry a serious hemoglobinopathy of the same type, then the child should be screened. At least we offer genetic counseling, we offer prenatal diagnosis, and if the fetus is carrying a severe hemoglobinopathy, we provide a reproductive choice for the parents so they can choose whether or not to terminate the pregnancy. And to my knowledge, almost all, if not all parents, they do choose that. And even if the fetus is not affected, then we offer the future pregnant, well, the parents the ability to do early prenatal diagnosis or pre-implantation genetic testing in future pregnancies, thus giving them the best conditions to have a reproductive choice in the light of these very serious diseases. So overall, we perform 5,000 tests a year, and it's increasing. Every year we do around 8 prenatal diagnoses on children where the parents live in Denmark. We also perform some for parents from Sweden, the western part of Sweden. And 25% of the tested fetuses on average, they carry a severe hemoglobinopathy in compound heterozygous form or homozygous form, and they are offered the reproductive choice. And it's safe to say, as in most other countries, that the screening program both prevents a lot of suffering, in our opinion. At least it provides the parents with the tools to choose on an informed basis whether or not to keep the child. And also from an economic point of view, it's also very effective, even though we have a very low prevalence country such as Denmark. Our screening program is definitely not perfect, and right now it relies on the GPs actually asking the parents whether they have roots outside Northern Europe and actually taking blood samples in the relevant cases, studying the children or the parents. So right now we are implementing a new strategy where we also look through the scanning database of all pregnant women who show up for the 12-week scan and see whether or not the pregnant women who have roots outside Northern Europe, we have that in the database as well, we look if they have been screened for hemoglobinopathies, and if they have not, we provide that option for them. We provide a digital mail, and we call them as well to provide that option. Regarding options, we also have different treatment options available. We have blood, very good blood donor service. We have high resolution blood group typing. We do that by NGS. And we also provide very fresh blood, less than 10 days old. The iron chelation is of course free for patients, and what we give depends on the patient preference and what side effects there might be. We also have some novel treatment options in therapy for therapy with mitapivat in the Energize studies, which are launching now. And if you have any candidates for targeted treatment of the thalassaemia, please feel free to call or write me. I'll be happy to tell you more about the options for Swedish and Norwegian patients as well. Luspatercept, we have tried that, but it needs to be on a specific patient-specific basis because it's not allowed for general uses in Denmark yet. It's approved by EMA, but not for general use by the Danish authorities. And of course, gene therapy we're ready to give it, but we're not allowed to give it, and it's currently not available anywhere in Europe. We have a comprehensive yearly checkup of all patients, social issues, different organ functions. We of course have MRT2 scan. We have liver labs for assessing precise milligram per gram iron in the liver. So we do a comprehensive evaluation of the patients. Our main thesis is that patients should be allowed to have a life as normal as possible. So that is the building block of everything that I do, try to make the patient's life as normal as possible. For sickle cell anemia, we do a lot of red blood cell exchange transfusions. I think that's pretty standard now. We do it at 3 different centers. We recommend hydroxyurea to all patients, children and adults, if they're more than 9 months old. We have L-glutamine, but we don't use it a lot. And we have AG946 in a phase 1 study that's upcoming. And then, of course, some of the novel treatments are only approved by EMA and needs to be specifically approved if we need it for a patient. We have a comprehensive yearly checkup, and I think it's very important that we have a collaboration with the palliation unit. So for pain management, social issues, besides the normal clinical workup at the hospital. We do transplants as in all other countries, but it's only in children. I have never done it in an adult patient, although it is of course technically possible. I have not found any patient where I thought it would be appropriate yet. So with that, I would like to thank you very much. And if you have any questions or comments, please feel free to write to me. And thank you very much for allowing me to tell about the Danish management for hemoglobinopathies.